Everyone. This is the Heartland Telehealth Resource Center, Oklahoma State University Center for Health Sciences, and Missouri Telehealth Network, Telemedicine Echo. My name is Tim Davis. I'm the Telehealth Manager for the Center for Rural Health at OSU in Tulsa. And I have the privilege of moderating today's session. Why don't we go ahead and have the Hub team members introduce themselves, and we'll go ahead and start with Rachel.
Hi, everybody. I'm Rachel Mutro, and I'm the director of the Missouri Telehealth Network at the University of Missouri in Columbia.
Great. Thank you, Rachel. Dina?
Hi, everyone. Dina Wheeler. I'm the executive director of the Center for Rural Health at Oklahoma State University Center for Health Sciences in Tulsa.
Great. Evelyn?
Hi, good afternoon. I'm Evelyn Nelson. I'm the PI for the Heartland Telehealth Resource Center and a pediatric psychologist at University of Kansas Medical Center.
And Molly?
Good afternoon, everybody. I'm Molly Brown. I am the director of the Heartland Telehealth Resource Center.
Great, thank you. I think that's all the Hub team that I can see. We do have quite a few participants, so we'll go ahead and refrain from having them introduce themselves today so we can have more time for lecture. So a couple of announcements. For a more collegial environment, we'll use first names during the session. So it'll be helpful if you make sure your name is updated on your Zoom profile. These sessions are being recorded and all materials will be shared following each echo. Please keep your microphone on mute until ready to speak. Use the chat box for any questions or use the raised hand function on Zoom to share comments or questions. If you'd like a certificate of attendance, please email us at htrc@kumc.edu, and we'll also put that email in the chat. So the goal of this Echo series is to facilitate collaborative learning and knowledge exchange among healthcare professionals to optimize telehealth delivery and improve patient outcomes. Our focus is to bring practical learning and case examples along with building networks to share information. So as part of our series, I'd like to introduce our didactic presenter today, Jordan Berg. Jordan is the principal investigator for the National Telehealth Technology Assessment and Resource Center, also known as TTAC, one of the two national telehealth resource centers. TTAC provides an in-depth and objective assessment for all types of telehealth technology. Jordan has over 16 years of combined experience working with the Alaska Tribal Health System and in telemedicine. Jordan is passionate about working with people, helping them to understand, evaluate, and assimilate telemedicine technology. Jordan, it's all yours.
Thank you very much. It's a real pleasure to be here. Hopefully my slides are popping in now. Again, my name is Jordan Berg. I'm here with the Telehealth Technology Assessment Center. We've really been diving pretty deeply into a lot of the AI applications, particularly with a look to what does rural healthcare kind of need to be considering and thinking about as we know. We've had a lot of conversations with a lot of folks, and the general impression that we're getting is that there's a lot of questions around there, like, I know AI is out there, I know it's important, I don't know what I need to be doing about it right now or how it applies to me. And so we're going to have a conversation today about some of the applications for AI in healthcare, what AI is, and a few other things. But we do want to set some expectations. We don't have enough time to go into any depth on any one particular topic. I've tried to hit the things that I think are probably going to be the most important for this group. It's such a broad subject, and it's actually impacting so many aspects of our lives that we can't really delve into it in probably the depth that it deserves. So this is going to be a high-level overview, definitely an introduction, and we'll hopefully leave you with some good things to think about and some good action items to kind of consider as you move forward. Let's talk a little bit about who TTAC is. TTAC is your federally funded telehealth resource center that's focused on telehealth technologies. We are funded through a grant through the Office for the Advancement of Telehealth, which is a part of the Health Resources Services Administration. We provide assessments for technology. We also are a resource for the 12 regional telehealth resource centers, as well as other individuals and organizations that are having questions about telehealth technology. This is our team here. I'm the person on the top, but we also have our technology specialist, Calvin Ross, there at the right, and then our marketing person, Patricia, in the left there. So what do we want to talk about today? So we're going to go over a few things. And again, at a fairly high level, we'll talk a little bit about what AI is. This is becoming a more and more challenging conversation to have all the time, but we'll give you a general definition. And we'll talk about some of the underlying types of technologies that we're considering when we talk about AI. We'll talk a little bit about why AI is so in the mind space of everyone right now. What's the hype around it? Why is it important for rural health? And then we'll talk a little bit about how AI is being used for patient care, in telehealth, and kind of some of the applications for it. And then we want to leave you with a couple key concepts to take away. As we go through the presentation here, just for fun and visual interest, I've actually created a bunch of different prompts where I had AI draw art for me. And so if you ever see some fun AI art, that's we're using the DaVinci AI art program. We set that up and we actually had it use the prompt that's given there. And it's you can kind of see what I was going for with the prompt and then kind of what AI was able to turn out. But a little fun AI in action, low risk, just for fun. So what are we talking about when we talk about AI? AI it has a lot of different definitions, and there's a couple key ones out there. The ATA has their own definition of AI. The FDA, the Federal Drug Administration, has a definition of AI. One of the things to think about is there are multiple definitions, and the definitions will actually almost tell you more about the organizations that are creating the definition than they will about the technology themselves. You can actually look at the definitions and see kind of what matters to those organizations. But in general, when we're talking about AI, we're talking about machines that think. Or don't really think because machines can't think, but machines that simulate the way a person thinks. And we kind of have to look back at what machines do well and what people do well. So what do machines do well? Machines are good at doing tasks over and over and over again, not needing any rest, and being able to follow instructions very, very closely. Humans are good at pretty much none of those things. But what we are good at is we're good at taking a look at a bunch of disparate information, drawing conclusions without having all the facts, and actually kind of making those leaps of logic where we can kind of see a pattern, we can see information that's emerging. So what if we were able to kind of combine the best parts of how machines work, how computers work, and the best parts about how people work? Well, we would have machines that are able to really better simulate the ability to kind of come to conclusions, to be able to look at messy data and be able to find the things that it needs in it and ignore the rest. So these are the things that we're hoping AI is able to do more and more in the future. But AI is the simulation of intelligence in machines, and kind of the application of that simulated intelligence to a variety of different problems. In general terms, what does AI do? And we can kind of break down some of the AI applications into 4 larger categories. And we're really going to focus on the first 2 today because I think they're the most applicable and most relevant to kind of what we're trying to talk about, which is artificial intelligence in rural health in the medium to short term. What is AI doing right now? What are the capabilities that we want to consider right now? And the first large category that we want to talk about is computer vision and machine vision. And this is one of the things that AI is very, very good at, is being able to look at a variety of different images and be able to draw conclusions about them. And it does this by looking at large sets of images, being able to figure out how they're similar, how they're dissimilar, and be able to, for any value of input, give you a value of output. So for example, the classic example is, we can train AI to actually be able to tell us when a picture is of a cat versus of a dog, by basically training it on a series of images of a cat. And then once we have that AI model trained, we can show it a new image that it's never seen before. And with a degree of certainty, it's actually able to tell us whether or not this is a cat. Now, we use the example for a cat, but the thing about when you train that model is whatever data set you train it on, it actually can be able to detect any of those things. So that could be cancer cells, or that could be diabetic retinopathy. That could be a variety of different applications and different things that we can have the machine be able to do. So that's computer vision and machine vision. And the two main categories under that are optical character recognition. And this is a machine's ability to actually look and decipher text in a variety of different languages, not just be able to read text in a text document, but actually be able to look at text on a page and be able to read, understand, and be able to use that information. And then object recognition classification, and that's exactly what we're talking about. And the other large area of AI applications that are really impactful for us today are generative AI. And this is the large language models that we're all becoming a lot more familiar with, your Chat GPTs, your Bards, your Geminis, all of these large language chat models, all of these large data set models that we can actually ask general questions to get responses back. In addition to kind of the chat bots, there's also a lot of generative AI that's used to create images and videos. And then another emerging space in there is multimodal, where you're actually able to put in different types of input and get different types of output. So you can put in text, you can put in images, and get out audio. So being able to use different types of media. AI is also really helpful in robotics, where we can give robots complex instructions and make requests of them in plain human text, and it will translate that into the programming for those robotic systems. So it allows us to really quickly and accurately use these tools without having to go in and actually program each of these things individually. And then another large category is expert systems. And we're actually seeing more and more of these being developed for healthcare specifically. And these are AIs that are actually trained on very specific and very limited data sets that are related to a particular field. So it could be related to population health. It could be related to patient data sets for a particular demographic area. But in general, these are kind of the four key types of AI applications, and we'll talk about what the specific clinical applications are for these a little bit later. But we wanted to kind of set the framework. I do recommend, as kind of a first blush, to understand the different types of AIs. IBM has put out a really good breakdown here, which we have linked here, and which we'll be able to make available from the slides. Before we get into much of the application of AI, I wanted to talk about why. Why are we talking about AI? Why is it really in everybody's heads right now? Why are we thinking about it? And there's a few things that are triggering this. And we're going to take these a little bit in reverse order here from what I have on the list. The first is we've actually kind of reached a place where the hardware and storage capabilities that we needed to make AI work have become really accessible to anyone really on the planet through cloud-based storage, through the rise of GPUs, which are graphics cards that are actually used for gaming. So the same graphics card that you might use to play, Grand Theft Auto, is actually really good at processing vast amounts of data very, very quickly for a single task. And that's exactly the kind of processing power you need for AI model generation. So we've had these devices become more and more powerful, more and more affordable, and this is really a lot of what's driving the growth of AI in this space. Cloud storage, we have affordable cloud storage from the big cloud providers. Microsoft with your Azure, Google and Amazon are the largest cloud providers. The other thing that's really driving AI right now is the amount of data. So healthcare is continuing to generate data across the globe. We generate 30% of all the total amount of global data higher than any other sector. We also are growing faster than any other rate at a 36% annual growth rate of our data. So we are generating so much healthcare data. Now, there's challenges with this data in that we have it all in disparate EHRs. There's not a lot of large uniform data sets, at least in the US, that we can kind of train some of these models on. But the information is there, it's being generated. And we can think about all the information that we're generating, even from the wearable devices that we have, like our smartwatches and our Fitbits and our sleep tracking devices and rings and things like that. There are two key maturing AI technologies that we'll talk about here in a little bit. And then really, I think what's generated a lot of the attention is generative AI. And that's these chatbots and large language models that we've all had an opportunity or are having opportunities to interact with. And it's really captured a lot of the public's imagination. The fact that I can ask a computer question and get a response back that is better than I expected it to be. Sometimes it's incorrect. Sometimes there's some hallucinations and things like that. But the ability for everyone to have access to our own kind of personal AI assistant that we can raise these questions with and get answers that in most cases were better than what we expected or had more capability than what we expected has really spurred a lot of interest and imagination. Kind of to that end, I want to talk about which of these technologies has potential for impacting our ability to deliver healthcare in the medium to short term, and which ones of these are kind of moving through this hype cycle. And some in the group may be familiar with this hype cycle. This is a Gartner tool that they create, and it really kind of describes the course of a technology and kind of how it proceeds from just being an interesting idea to being something that we can use every day. And I want to point out the 5 different pieces of this hype cycle. And then we're going to talk about a couple key technologies and where they lie on this hype cycle chart that Gartner created for us. And this is a tool that's used for really any kind of new emerging technology, and it's kind of a thought experiment. The first thing we see is the innovation trigger, and this is just kind of when the technology enters our consciousness. We start hearing about it, we start thinking about it, and then as more and more of that people become aware of it, more and more people become interested in it, we reach the second point there, which is the peak of inflated expectations. And this is where we expect the technology to solve all of our problems. This is the answer. We've been waiting for this. It's going to do all the things that we expect. And it's going to be able to, it's going to be able to fix all the issues with our systems that are broken. Then we realize that, hey, that's not really going to happen, and we become sunk into the trough of disillusionment. So we become kind of depressed about the technology, and we're like, no, this is all garbage. We hate it. It's not going to do it. We're not going to be able to get what we want out of it. But as we limit our expectations and as we begin to think of how this technology can be used more practically, we start to come out of that trough of disillusionment, up that slope of enlightenment until we actually reach the plateau of productivity, which is where these technologies are going to deliver the best application for us to be able to do what we want them to do. So all that to say, that's a 30,000-foot view of what this is. This is a hype cycle that Gartner created, particularly for artificial intelligence back last year. And I wanted to point out a couple of things on this, and this might be a little bit small. Hopefully everybody can see this. But if we look at what's on, what AI technologies are on this slope and kind of where they're at, I want to point out a couple different things. So first we have generative AI, and that's really at the height of that hype cycle. So these are those large learning models. These are the chatbots. These are all of those technologies that have generated so much interest and have captured our imaginations. And they really are very, very hype driven. So there's some capability there, but we're really not sure how that capability is going to translate into actual productivity over time. If we look a little further down into that slope of disillusionment, we see edge AI. This is artificial intelligence that's built into technologies. So that might be a stethoscope, or that might be a MRI machine. So these are AI capabilities built into technology directly. But if we continue our looking to the right there, what is AI actually doing that's kind of mature, and what technologies are we actually looking at that can be expected to drive change for healthcare in the next 3 to 5 years? We can see computer vision and data labeling and annotation are really kind of a lot of what we can expect to be driving those changes. And we've seen this in the ability of AI to deliver in our diagnostic analysis around radiology, around lab work, around diabetic retinopathy. These are the things that are actually reaching a level of maturity and are actually being able to impact our ability to deliver care. So I share that just to mostly kind of let us look at kind of to set our expectations about what these technologies are for and what they can do. Why is AI important? It's really important for a lot of the reasons that we think telehealth is important. AI has the ability to address some of the shortages that we are really impacting, are probably the greatest impactors of our care. So staff shortages, particularly in providers. We have providers that are, we have way too few providers for the care that we're trying to deliver. And that we also have staffing that's under for what the care that we're trying to deliver. We have a lot of patient populations that are very rural and aren't able to get access to the care that they need. And that we have this increasing volume and accessibility of patient data, but we have no way to process it. We have no way to really take that data and turn it into insight. And AI is posed to be able to help us address a lot of these. We've actually broken down some of these AI applications into what we feel are 4 key areas. The first, and we're going to kind of gloss over this a little bit just for sake of time, but the first is patient focused. These are AI tools that are designed to interact with the patient. And what we've seen a lot in this space is some chat triage functionality that we've been able to direct patients to the correct specialty, to correct provider type, be able to ask some of those initial questions and collect some initial demographic information. And that mostly that's in a chatbot form. We've seen a lot of symptom checkers using AI technology that have cropped up all over the internet. It's like WebMD kind of on steroids. But these are mostly for educational purposes. We've not really seen these kind of enter into the verified clinical application space. We are seeing AI tools used to help with virtual visit check-ins and technology checks, and then doing a lot of some of the more tedious work, reminder automation, making sure patients are showing up for appointments when they're supposed to be there. For our discussion today, where I want to spend a little bit more effort or spend a little more time is in provider support. We're going to hear a little bit more from the other speaker today about this more directly. But where we think providers are going to get the most benefit from AI in the very short term is around visit documentation. So we've already had quite a few tools out there that are kind of designed for scribing and charting. Most of these are driven through the electronic health record. They are kind of focused on increasing the improved speed and accuracy of dictation, but that's just the first step. So what we're actually seeing for a lot of these AI tools is that they're actually able to listen to what's actually the interactions that's happening between the patient and provider, and potentially multiple speakers within a room. So there might be a patient, a provider, a caregiver, a spouse or a child that are actually in these visits. It's actually able to identify all the speakers and then able to summarize everything that was said, and then actually move that into a clinical note with a variety of customized templates and references that can be created. In addition to that, we also are seeing AI technologies that are used for medical record summaries, where they're able to go through a patient's EHR record, actually comb through for relevant medical findings, and create a summary for the provider. Now, all of these are things that are kind of happening in parallel with the provider, where the provider is actually able to go through, look at the note or look at the record summary and verify and make sure that those things are correct. We're also seeing a variety of decision support tools that are being more and more combined with the scribing and charting, helping to create plans. again, all of this is really, really EHR driven. And if we think about how a lot of these AI tools will be being used in rural health, we can pretty much expect that the EHR will be the gateway for a lot of these new services and plans that will actually be able to access these through our Epics, through our Cerners, and actually be able to use these tools either as an add-on or as part of the base service for a lot of the electronic health records. One of the areas that we're really interested in that's more around the corner than actually right here and now is for ambient vitals collection. The clinic room of the future will likely be one that we can actually take heart rate, that we can actually take blood pressure and temperature all from inside the room itself without actually needing to even touch the patient. And that's another thing that AI is, we're looking to AI to help us do, is to actually, when the patient walks in the room, that we're actually collecting all of this information through cameras, through other sorts of sensors that are built in and ambient to the clinical environment, and actually building clinical spaces to actually collect this data. Now, that's still a little bit more in the realm of science fiction at this point, but it is something that we're seeing a lot as we are looking at new and emerging technologies. The other areas that AI is the most impactful are around administrative and business support. These are the less sexy places for us to use AI, but potentially some of the most impactful. So AI that helps us collect patient demographic information accurately the same way every single time. AI that helps us code and build better. AI that helps us do our data analytics. AI that looks at our process improvement and revenue cycle and makes recommendations there. These are kind of the practical applications that are actually already being embedded in systems, enterprise management systems, into our procurement systems, into our billing and coding systems, even now as we speak. They're not going to be patient visible, and there may not even be provider visible, but they are kind of helping us to make those changes. The other big place that we're seeing AI applications is in diagnostics. And we've talked about this a little bit. AI is really good at looking at X-rays, really good at looking at MRIs, really good at looking at lab work and being able to identify, flag, note, annotate rapidly right in the moment. We're also seeing a lot of devices that are useful for diabetic retinopathy. In fact, screening tools that were actually able to look at diabetic retinopathy images and actually detect undetected diabetes in patients who've actually not had, have not been ever diagnosed with diabetes, but from the diabetic retinopathy exam, they can see those early precursors and actually let patients know that they are at risk or have diabetes. The other big area that we're seeing in diagnostics is in cardiology. There's a variety of AI-enhanced stethoscopes, ECGs that we can use to measure and track trends for cardiology patients. We're going to go over this really quick. There are a lot of concerns and risks around AI. I really want to focus on risks of AI for rural. Specifically, we're going to need to find a way to be able to use these tools in a cost-effective way. We're going to need to find ways to scale them where we can actually deploy them to the most rural places that really need them. And we're going to need to be able to do that in locations that don't have infrastructure of larger organizations. And that's really where I think we will see the EHR as a gateway for a lot of these AI tools, at least in the medium time frame as organizations are looking for these. The other challenge that we have is a little bit like some of the challenges we had around telehealth during COVID. There's absolutely the potential that providers could be using ChatGPT to help them do their SOAP notes, or they could be using it to help them do some differential diagnosis. And we need to make sure that the tools that we have are HIPAA compliant, that we're doing the privacy and data security that we need to do to make sure that they are that we're following best practices. And the fact that these tools are out there, that they are available to everyone, we need to make sure that we're training and communicating with our providers about using the right tools in the right ways. A couple key points we want to leave you with. If we're looking to deploy AI for our organizations, we want to be as specific as possible. Generalized AI solutions are kind of popping up everywhere, but AIs that have a defined job, defined data sets are going to be a lot less prone to hallucination and a lot more likely to give us the results that we're looking for and not to create more risk problems for us. Even small organizations really need to start having more and more in-depth conversations around data governance and risk management around their data sets. If we are using tools, if we are using even through our EHRs that we, kind of trust and have come to rely on more and more, we need to make sure that we understand how they're using that data, how they're managing risk from their end, how our providers are managing risk from our end. Here, I've linked two kind of helpful resources around data governance and risk management, specifically related to healthcare and AI, respectively. So that was, again, a 30,000-foot view. We went really, really quick, but I wanted to kind of give you guys an overview of some of the potential applications of AI, particularly focused on rural healthcare. And I want to thank you guys for your time.
Thank you, Jordan. Appreciate that. That was great. If possible, we can wait until after the case presentation for any kind of Q&A for both sides. So now moving on to our case presentation. Our next presenter is Dr. Ashton Clayborn. She's the Chief Medical Information Officer at Choctaw Nation Health Service Authority and is a board-certified family medicine physician. She received her DO and MS from Oklahoma State University College of Osteopathic Medicine, Go Pokes, and began her career with the Choctaw Nation in 2014 as a resident physician. She returned to the residency program as a core faculty member and in 2021 became Choctaw Nation Family Medicine Residency Program Director. In 2023, Dr. Clayborn was appointed as CMIO to serve as a clinical leader in Choctaw Nation's EPIC implementation project. She is currently working on clinical informatics subspecialty board certification, and upon completion of the EPIC implementation project, plans to continue using data and technology to improve patient outcomes, population health, and physician satisfaction and efficiencies. Dr. Clayborn is passionate about advocacy and solutions to improve healthcare in rural areas. She serves on the Board of Trustees for the Oklahoma Osteopathic Association and lives on a small ranch in southeastern Oklahoma with her husband and 4 children. So welcome, Dr. Clayborn. It's all yours.
Thank you. And thank you, Jordan. That was very helpful information. As you all probably can gather from my bio, I am a small town girl who does love technology and data, and I've always loved research, but I like it in the sense that I feel that it can be used to really improve our lives as healthcare providers and the lives of our patients. So being able to bring science and new technology to the workforce that I serve and to the patients that I serve, I think is what's so exciting about all of this. As we move forward, I will just say, whenever I got the invitation to speak here, I would love to be able to tell you all that we are so far advanced and we have all of these great technologies already in use. But from Jordan's conversation, you can also hear that many of these things are so rapidly evolving. I get to tell you a little bit different information today, and that is kind of where my workplace is in just really researching and determining what it is of these technologies that we will be able to bring to our providers and to our patients in the future, and kind of what we've seen and what we've been through so far. So hopefully just some of that experience will help someone here. I am far from a techie. I like to joke that I was put in this position because of the opposite of that, quite truthfully, and that is I see the advantages of technology, but I'm also someone who was probably born about 20 years too late, and I've seen the paper world and how efficient in some ways that could be, and I want to be the bridge of that gap between efficient old school medicine and really focusing on our patients and using technology to make that happen in the future. So here we are talking about the impacts of technology on advancement of recruitment and retention in rural and underserved healthcare facilities. And Molly, I'm assuming it's you that I'll be saying next slide too. So if you don't mind advancing there, I'll do my best to keep that as seamless as possible. As disclosures, I don't have any affiliations with any of the companies that I'll be mentioning today, and I'm going to try to leave them very generic and just provide you all with basic information. But I am employed by Choctaw Nation Health Service Authority as the CMIO, as mentioned. And I will discuss features of our health system. We are a rural tribal health facility, but my presentation today and the information I'm giving you just represents my own experience and opinions and things that I've collected, not that of Choctaw Nation. Next slide, please. So to give you our background though, Choctaw Nation is a 54-bed hospital in Southeast Oklahoma, far southeast corner of the state. We do have obstetrics and a labor and delivery service. We have a small ER, and we have an ambulatory surgery center. Our surgery center in Telehealth does short admissions post-op. We also have a large facility in Durant that is daytime only without a hospital. Throughout Choctaw Nation, we have approximately 140 physicians, PAs, and nurse practitioners across multiple specialties and throughout multiple satellite clinics. We really cover an area that is about 10.5 counties, or almost a quadrant of the state. The outpatient primary care is our predominant service and where the bulk of our visits occur. Next slide. Recruitment challenges. So if you are here listening and you are from a rural area, you probably understand this better than anyone. But part of the trouble and part of the issue with getting people to come and serve in these locations is just that. It's the location itself. Now I posted a picture of the Talamina Drive because to me, the very things that make it difficult to recruit others are what keeps me in the area. I grew up here. It's home. I love the fact that we don't have some of the issues, we'll say, of larger urban areas. But to many people, those are conveniences. So it's seen as an inconvenience to them or a drawback of moving to a rural location. Our main campus is in Telehealth, which has a population of approximately 923. There we have $2 Generals, 3 gas stations, 1 Family Dollar, jokingly FDDT, Family Dollar Dollar Tree, if you're familiar with that chain. But we more recently did get a market, but until then we were also kind of a food desert. There was not necessarily access to even fresh fruit and vegetables in our stores. There is a small public school, which again, I feel does a good job of training our students and our youth. But while that's a dream for some people, and as I mentioned, it's my dream to stay there, it's less desirable for others. They look at that and go, some people put it on the Walmart scale. Where's the nearest Walmart? And for us, that's about 40 to 45 minutes away. Poto would be the nearest to Telehealth, as far as Walmart is concerned. Things have improved with Amazon and shipping and all of that, but it's still a different lifestyle. And if you love it, you love it. If you've never been there, it can be seen as a challenge to overcome. And it certainly can be a challenge for physicians who have been trained in more urban areas, and we're trying to convince them to then move out to these areas. Also, our satellite clinics at Choctaw Nation are in similar or even sometimes smaller rural areas. So that has been an issue historically for Choctaw Nation. And prior to 2012, turnover was very, very high. So there came a time at which Choctaw Nation became, well, they were always visionary, but said, how can we better serve our people? How can we reduce turnover? And they came up with some solutions for that. And, we already said go Pokes, but OSU is my medical school, has a mission of serving rural and underserved populations, especially tribal populations, and putting physicians back in those communities. And so OSU's vision has over time really aligned with the tribal nations on serving their people. And some of these strategies you'll see probably overlap with what you've been exposed to, and we think that's a wonderful thing. So a little bit of what I'm talking about today will probably represent that overlap, but we'll talk about how we plan to see that move forward as well. Next slide, please. So one of Choctaw Nation's solutions was to grow your own. And yes, that's me in the middle. I was program director at that time before this role. So I have a passion for academic medicine and the mission of OSU and Choctaw Nation in seeing that happen. But visionary leaders of our health system, including our current CMO, so not the CMIO, but our chief medical officer, wrote a HRSA grant to fund a family medicine residency program. So I think OSU and many others have shown data to say that where you train physicians, 50% of them will stay within an hour of that area. So if we can train them, we can keep them. and that happened at Choctaw Nation. So graduates from the residency now serve in the ER, in the inpatient unit. They serve all over in our satellite clinics, in places that were previously very difficult to staff. They serve as administrators and academic faculty. So the residency program was just a glowing picture of success of what Choctaw Nation and OSU have always tried to accomplish in that. The residency, it's now a 4-4-4 program and has over 25 graduates historically, over 70% of which still work for Choctaw Nation, and over 90% still work in rural and underserved areas across the nation. So this solution was more than just an idea. It actually has now proven to be very successful, and I'm happy to report that. So how does that all relate to IT and what we're talking about today? Let's go to the next slide. We have to keep them. So how do we figure out ways to do that? Well, in the beginning, Choctaw Nation created very competitive benefits. They recognized that housing was a big issue in rural locations, so they provided housing for the residents. They've always promoted a culture of physician leadership and respect, knowing that docs really do just want to spend time with their patients and not practice corporate medicine to the degree that we lose that relationship with our patients. And they've given us the ability to provide that care the way that we all envision when we go to medical school. No one sits down in their interview and says, you know, I want to make the most money for someone else out there and see 40 patients a day. Most people, you know, my answer was, I want to take care of those around me. I want to spend time with my patients. I want to do holistic medicine, get to the root of their problems. And I think you'd have a hard time finding many docs who would differ from that with their vision when they go into medical school. So what does that mean, and how can technology help us not transform into that, but to maintain that? Next slide, please. So how do we support that quality care? And how do we do that using some of the tools that Jordan mentioned during his talk? Choctaw Nation started with a virtual scribe pilot project. So again, we're not fully using AI just yet, but this is what they have started looking at and kind of where it's taking our health system in the future. So we started with just a few more than 10 primary care physicians using virtual scribes. The app records in the room, and the AI question mark there is just to say, I cannot guarantee that there's not already some AI being used to help kind of pre-generate the notes. The company has not fully confirmed that with us, but we do believe that there's probably some pre-generation of a note. And then those recordings are scribed by physician graduates, so MD or MBBS graduates in India. They also have a branch in Mexico, I believe now. And the note is created and it's back on the chart by the next morning. And again, that was just kind of a pilot project. Visionaries, the same visionaries that said we need to grow our own docs and keep them, said, okay, now let's look at the future and find some tools to help ensure that we continue to be on the forefront of medicine, keep these doctors happy, and maintain their relationships with their patients. And so what we've seen coming out of that small pilot project, these were docs who were already higher producers in the health system. So we didn't see this huge jump in productivity. I would anticipate if they were lower producers, you would expect to see more, but we did still see a slight increase there. But more than anything, we saw their satisfaction increase. So when they were previously spending lots and lots of hours after work, and what we call pajama time, or the time spent charting outside of office hours, these docs are now leaving work on time, and they're reporting that they rarely work outside of their duty hours. But we've also found that this service is very costly, and it's not at the current price, not scalable to our entire medical staff. So that's kind of the current situation we're in, and the direction that we plan on taking in the future is trying to get that wrapped into a service that we can afford to spread enterprise-wide. Those docs that have it, they do insist on keeping it. They say it doesn't have to be this, but we need something very similar. And, you know, our health system may not pay as much as larger health systems in the area who are working on different payment models, but they're able to live where they want to live, close to home, and able to provide care. I think if you ask most of our docs what keeps them working for our health system, it is being able to provide care in the way that they envision themselves doing it, as I mentioned earlier. And so us finding a way to make that manageable and yet still make our health system profitable enough to keep the doors open is important. Let's go to the next slide. So here's what's next for us. Reducing that cost, seeking additional benefits in the new technologies. Jordan mentioned several of them, and it just continues to evolve. We're currently implementing Epic And so we have currently kind of had to put a short pause on pursuing all the AI technologies at the moment, simply because we had to secure necessary third-party contracts to keep this project moving. But we are very soon to resume those conversations and do some more research. We did already do some early research though. And so in just a moment, I'll present some information to you all from various options that we have. And we're just going to continue to gain more information, although most of this is available online. So I'm not here to just like sell you on all the different options that different companies have, rather than just share some basic info that we've collected. And maybe that will be helpful to someone out there. We did learn that, in talking to these companies, the current virtual scribe service we have that involves humans, it's reported to have, quite good outcomes that are human reviewed in comparison to some of the AI note generators. But we just continue to see that evolving so rapidly too. I have colleagues, again, at the state level that have reported at some of our meetings, they're now using some of those services that were considered to be inferior to our virtual scribes. And they're now catching up and saying, hey, I'm already using the service and it's actually going really well. The notes have already gotten better. So I think the computers are learning as rapidly as we would hope they are at this point, which is very exciting. Epic, being such a large company that it is, also does interface with many of these companies, but that is also evolving as well. So being where we're at in our implementation project, we're trying not to jump too far ahead. We want to make sure that we choose the product and the company that work best with what we're already putting in place for the time being. And now we'll move to a comparison table just so I can share a little bit about what we've gained. So we do have several options. And here's just some of what we've collected. Again, you can Google companies out there and see what they have to offer. But if you're just going, okay, what's out there? Kind of what price range is it in? This is a little bit about what we've gained. So with option one, we had an AI and a virtual scribe service, and that company does offer options for additional virtual assistant services. It was even higher than this to begin with, so our contract was upwards of $3,500 a month per provider, and that's been negotiated down. And the more AI we use in that, the less human service and the more AI service we use, the more that price actually gets driven down. In comparison, though, I think it's important to note availability, because when there is a human involved, it takes longer than an AI generated note. So currently we are actually not getting those notes until the next day. And we do feel like with the AI component, we'll actually be able to see that turnaround time improve. One nice thing about that option that I'm discussing that we currently have our pilot project with now is that you do have the option to toggle between AI and the virtual scribe. So that is something that's kind of unique to that company. The next option is one that provides speech to text with commands or virtual assistant services, but that's actually already included in the basic license. And that was something that was news to us. So again, not here to tell you all every piece of every company, because that wouldn't be my role anyhow, but it was enlightening to us to learn that one of the licenses we already have for a speech to text service actually does include more of a virtual assistant service than what we even knew we had, and we'll be able to recognize that as we move forward into Epic. And if you look at the cost comparison, so if we just talk about the service we have right now, with our speech to text license, it's on the lower end of that. So that $100 to $1,000 price range, we actually already have more of a service than we even knew we had. It's just that our current EHR didn't support it. That one will generate those notes, and that will do it almost immediately. And so that's another very strong option for us to consider. A third company that does similarly is in a similar price range, again, just kind of depending upon the level of service that we would choose there, but also providing immediate notes. I'm going to jump over to option 5, and that is one you all, if you have Facebook, social media, you're probably getting targeted ads on your phones, just like I am, of some of these services. Just to name one, AI Freed is my phone sitting here. So in the next 10 minutes, it'll show me even more ads now that I mentioned it. But many of those companies are starting to advertise. I'm sure you've seen them. They are very affordable in about the $100 a month price range. And some docs are just kind of using them on the side with agreements with their companies. or their employers. So that's another option, even for docs who are already employed, but maybe are able to have a standing agreement with their workplace. They might be able to do something standalone. Now, Jordan did mention data governance and contracting, and we actually just discussed that in a meeting here this morning, how important it is as this technology evolves to involve your IT team, your data governance team at your health system. I mean, these were things that really didn't even exist in our health system, especially data governance, until very recently. So not only is the technology evolving, but the legal structure and the governance structure and the need to be mindful of those things is evolving along with us. And I do feel like I've learned a foreign language in the past 6 months, but hopefully that can help others as they begin to navigate this process and recognize sometimes it's not quite as simple as just signing up with a company and paying my $100 a month membership. There may be other legal hoops or, again, data governance, privacy issues that we need to address as we navigate moving forward with these new technologies. And then lastly, option number 4, I just wanted to mention that one. Jordan did mention other office components coming into place. So there are some companies that offer more of a full-bodied service that includes additional billing and coding and automation there. And one of these we've looked at has lots of options available. Depending upon the level of service we were to choose, it's anywhere from $400 a month up to $1,000, but a very robust service. So again, I'm just sharing this so you all can see kind of some differences, but the one key thing I wanted to highlight is just knowing that if you already do have some of these technologies, like a speech-to-text license with something like a Dragon or a Fluency, look into your existing contracts and just see there may be services that you're not even fully aware that you already are paying for and have access to, that just need to be fully recognized and realized. So here we are, and this is why we're in a hurry. We're very excited, but we're also really trying to take a step back and not just jump head over heels into something that is so rapidly evolving, knowing that we're going to continue to see the technology evolve, but also see these price points driven down and the services that are offered continue to expand. Next slide, Molly. So just in closing, I am so excited. For us, the next step is just figuring out with demos. As I mentioned, we were kind of on a brief pause for a little while our contracting team here at Choctaw Nation was focusing on other parts of the Epic implementation, but we will be rapidly now exploring all of our options, and that spreadsheet will probably become much more robust with even more information, and we'll get to soon make a choice on what it is we bring into our health system. So just circling back, as Jordan mentioned, I can't speak to all the specifics and what AI has done for us at this time, but we know that in rural healthcare, the problem is getting docs and keeping them and maintaining those relationships with our patients. And we're really excited about what technology can do for us in maintaining that and moving us forward. So thank you all for your time today.
Thank you very much to both you, Jordan and Dr. Clayborn. So really quickly, we have a few minutes for any questions. If anybody has any pressing they would like to ask, you can still drop them in the chat and we can address them after the echo in our follow-up email. I do have one question for you, Dr. Clayborn. In your discussions and with your team reviewing all this, how are you considering training? Is that part of the conversation now, or are you holding off until you make some more concrete decisions following your demos?
Much of it will need to be after our demos, but those who are currently doing the pilot, they will be the largest participants in those demos. So they'll already have some idea of kind of how that will work, depending upon our time frame. So if we move forward faster than I think we will at the moment, it's possible that we could roll some of this into the already established training structure that will be our Epic implementation training. So some of this could be rolled in if we're at that point where we're ready for that. And if not, then, again, our employer, I'm very fortunate to say that we're well supported in just being given a little bit of time to do things like that. I don't want to say it's not a concern, but We will likely roll it into some of what we're doing with Epic. Even Epic's own AI is rapidly evolving. So some of this that we're currently looking at third parties for, within the next few months, we may see that Epic has developed some of their own, and some of those services might not be necessary as third parties even. So a lot of it will get rolled in. And then, of course, the other thing is just developing the policies and procedures to support not only the services themselves, but the training in advance. We currently don't have an AI policy, but we're drafting one. And as we draft it, we'll make sure that it supports everything that we're trying to implement so that it fits both now and in the future.
We do have another quick question. Have you had input around patient reaction as they learn more about the use of these technologies?
Yeah, we've actually had some, and I think if anything, I've been surprised. I thought there would be some hesitancy and some fear of outside sources potentially having access to patients' information. But many of them just truly, they want their doctors to be happy. They want that relationship with their doctor. And, most of them probably, and it's not the best approach, but I will say when it comes to my cell phone, if I need an app on my phone and I need to be able to use it, I just blindly agree to a lot of things I probably shouldn't. And I don't know how many of you all are guilty of that. In some of my master's courses for informatics, I've learned that, that's probably not the wisest thing to do, but we all do it probably. And the patients are actually very accepting of that, I've found too. If they know that their health is going to benefit, their relationship with their doctor is going to benefit, there has not been a whole lot of hesitancy around it. And I think in general, that's what we'll continue to see. I, of course, do want to be the watchdog for my patients in that and making sure that their data and their privacy is supported. But I think the biggest thing is, just like everything else, informed consent. If the patients are fully aware and no one's trying to hide anything from them, they're more accepting. And I think that's the best thing we can do, is just to continue to keep them as informed as possible.
Great, thank you. Again, if you have any more questions, pop them in the chat and we'll make sure to copy them down and get back to you and include them in our follow-up email. Just as a reminder, our next ECHO will be held on August 13th. At noon at 12 p.m. and we will be sending calendar invitations soon, as well as additional information about that. For this session, Dr. Evelyn Nelson will present practical tools to reduce digital burnout, so be sure to tune in. Again, please email us if you would like a certificate of attendance for this session. We will be sending our follow-up email that will include the presentations from our presenters today, as well as the recording. So please email us if you would like a certificate of attendance, and then also if you have any additional questions for our presenters. Thank you all and have a great day.